Okay, I'm going to get started. Hi everyone, I am Annie. I'm one of the EM registrars, second year, and I just wanted to give this talk on pediatric cardiac murmurs, and it's basically just a ED approach to them. It's not by any means an extensive talk into various specific murmurs, but I think it's good to have an approach on which murmurs we should be worried about and which ones we could maybe think a little bit more about, maybe that this is an innocent murmur or such. So it's an approach. Please ask questions at the end if you have any burning ones, and I will try my best to answer them. Cool. So why cardiac murmurs in the first place? We can see that innocent murmurs in children can actually occur in up to 20 to 80% of children. Infants with cardiac murmurs, 0.6 to 8.6% of them will actually show no signs of congenital syndromes. So if these innocent murmurs in children actually occur in such a wide sort of variation of them, it's important for us to distinguish which are the ones that we should be concerned about and urgent referral, and the other ones that might just be a common childhood murmur. So what exactly is a murmur? So a murmur is a relatively prolonged series of audible vibrations characterized by all of the above mentioned features. So timing, intensity, frequency, the quality, the configuration, the duration, and the direction of the radiation. So it results from changes in blood flow, or basically turbulent blood flow caused by pressure changes or velocity gradients. So usually innocent murmurs are classified as that because they are functional or systemic murmurs, or murmurs that occur in response to systemic changes, such as an increase in blood flow. And so they also are sometimes called flow murmurs. The pathological murmurs, I think we're quite familiar with, are usually due to a congenital or acquired dysfunction of the cardiac valves. And because those valves are dysfunctional, the valves result in turbulent flow in the blood vessel or in that chamber, and that leads you to detect or hear this vibrational sound quality. So just to remind us over here about the different heart sounds that we do have. So we have our S1 and our S2. And then just important to note that our systolic murmurs, where they occur, so between S1 and S2, and our diastolic murmurs between S2 and S1, that becomes really important in when we're differentiating between systolic and a diastolic murmur and other additional sounds that can actually help us determine whether or not this murmur is innocent or pathological. And then just to go on to the grading of murmurs, this is actually the grading of most systolic murmurs, is grade 1 to 6. And I don't think it's really important to remember every single grade, but knowing that grade 4 is when you have a palpable thrill, and a thrill is a palpable murmur. So if you put your hand over that area of the precordium, you can actually feel what you can auscultate with your ear. And I think that's the delineation between sort of grade 3, which are, or grade 1 and 2s, which are quite soft murmurs, anything from a grade 3 up, which is quite a harsh and harsh sounding murmur. So in our ED approach, obviously, we're going to do a comprehensive clinical evaluation. And the first part of any clinical evaluation that we're going to do is going to start with our history taking. So in our history taking, we're going to look at the specific history, the family history, the family history of the entire family, the obstetric history of the mother, the maternal obstetric history, any genetic syndromes that the patient might have, and then the history of that particular neonate or infant themselves. So if we're first starting with the family history, we first have to look at whether there's a family history of congenital heart disease, and they actually state in the literature that having a family history of congenital heart disease increases your risk of CHD by 3 to 24 times higher than the general population. Whether you have a family history of hypertrophic cardiomyopathy, as that can also increase the risk of that patient having hypertrophic cardiomyopathy, and if there's any family history of sudden unexplained death, that's because usually we get worried about there being an undiagnosed genetic cardiomyopathy or CHD in the family if there's a sudden unexplained death. We move on to the maternal obstetric history. And firstly, we look at any first trimester infections the mother might have suffered. Rubella is actually often associated with PDAs as well as pulmonary artery stenosis. We look at whether the mom had any maternal illnesses such as diabetes or whether mom's BMI is more than 40. Infants of diabetic mothers are 3 to 5%. 3 to 5% of those infants will have associated aortic, vascular, or endocardial problems as well. And infants born to mothers with a BMI of higher than 40 have an increased risk of ASD as well as PDA. Then we're going to ask the mom if she was exposed to any teratogenic medications during her pregnancy. And there's a whole host of medications that we can list, but specifically just to name a few, we've got valproate, warfarin, ACE inhibitors, retinoic acid in sort of the first trimester. And then actually in the third trimester, NSAIDs given are associated with premature closure of the ductus arteriosus. Then we're going to look at any genetic syndromes that are associated with or that this baby might be associated with. So we're going to look at particularly T21 and Turner syndrome, and we know that has a high association with congenital cardiac abnormalities. We're going to look for any connective tissue pathologies, inborn errors of metabolism, and then importantly, they talk about this more than 3 minor structural abnormalities or 1 major anomaly. And I don't think it's important for us to know sort of the genetic syndromes that are associated with that, but kind of this is just to know that when the peds talk about Vactral or Pierre-Robin sequence or Catch-22 syndrome, these have a higher likelihood of being associated with a congenital heart abnormality and should just raise your suspicion that this child might be at a greater risk. The next thing we're going to look at is the personal history of that neonatal infant. And we're particularly looking for any features or signs of heart failure. In the neonatal period, they state that actually murmurs that occur in the first 6 hours of life are usually associated with a valve problem inherently, so either regurg or stenosis, and murmurs after the first 6 hours are usually associated with shunt lesions. In the infant, it's a little bit different. So murmurs detected beyond the age of 1 year old are usually innocent, but they have specific features which we'll go into later. Then in terms of looking for specific features that are going to worry us in that child, is there any history of syncope or near syncope? Is there any neonatal respiratory distress? Is there any chest pain in an older child or palpitations? Is there any persistent central cyanosis, excessive fatigue or dyspnea, poor weight gain especially, and a failure to thrive, and then any sternal or anterior chest wall anomalies. And those are all going to raise our suspicion on history. So now we move on to our physical examination of this child. And everyone wants to jump to the cardiovascular examination, but remember that we also need to look for vital signs, whether they're appropriate for that age of the child. Our general examination, including examination for clubbing and more features, because that's going to tie in with what we were talking about now, specifically with genetic syndromes. We're going to look at heart rate and rhythm, and we're going to examine our pulses, whether they are equal bilaterally, especially weak femoral pulses that suggest a coarctation of the aorta, or any differential pulses in patients with supravalvular aortic stenosis. And then we're going to move on specifically to our cardiovascular examination. So when we move on to our cardiovascular examination, we're going to do our typical inspection, palpation, and auscultation. And we know about inspection, specifically the chest wall deformities. In terms of palpation, we've already talked about a thrill that you can palpate, but also a palpable P2, which is your S2 component split into your A and your P component. And then we're going to auscultate and listen for any additional sounds that are going to indicate to us that this is actually a pathological process that's going on. So we've spoken about auscultating and we've spoken about murmurs. So I just want to quickly remind us about the types of murmurs that we can have. So the first is the systolic murmur, and that is both our murmurs are classified by timing. So we've got our systolic murmurs, which can either be ejection, mid, late, and holosystolic or pansystolic murmurs. And the first example I'm going to play here is actually that of an ejection systolic murmur. Okay, so we can actually hear that that murmur peaks in sort of the middle, beginning to middle of that systolic phase. Just want to check that everyone can hear the murmur. Someone just say yes. Anyone?
Yes, I can hear the murmur.
Okay, great. Cool. And then, so that was an ejection systolic murmur. And listen to how it's different from the holosystolic or the pansystolic murmur. That murmur, the S1 and the S2 are almost softer because the murmur takes precedence over everything else. All right. So those are our main types of systolic murmurs, especially the ejection and the pansystolic murmur. Then we've got our diastolic murmurs, which are also classified into early, mid, and late diastolic. These are notoriously harder to listen to. They usually require a softer room where you can focus on this murmur and not a thrashing or uncomfortable child. So they're going to be quite difficult for us to listen to, but it's important for us to actually hear what they sound like so that we can recognize them. So to me, that it's a lot more of a slightly musical quality, but almost sounds like a wheeze in the end if you listen to that carefully. So important for us to just remember the differentiation between the systolic and the diastolic, and then of course we get our continuous murmurs. I've put most of the common causes in the top there, especially our PDAs, also called machinery murmurs, and these are murmurs that actually begin in systole and then end at the end of diastole. And they are defined that they extend up to diastole without interruption, but they don't need to necessarily occupy the total duration of systole and diastole. They just need to extend into diastole. And that's probably a little bit harder to hear because it is quite tachycardic, but it's important to note that you kind of hear sounds in both parts of the cardiac cycle where you shouldn't be hearing any sounds. Okay, so I've been talking about these innocent and these pathological murmurs, but actually how do we differentiate between innocent and pathological murmurs, especially in a child? And I really like this that I found, which are the 7 S's of innocent murmurs. So a murmur, to be classified as innocent, has to meet all of these criteria, with the exception of a venous hum, which doesn't meet any of these criteria, but it is still classified as an innocent murmur. So the murmur has to be soft, systolic. It's actually sensitive to changes in position. It has a small area of the pericardium involved. They almost talk about it having this musical quality, not that harsh sound that we heard in the systolic murmur. And it has no additional hard sounds, no opening snaps, no clicks, nothing else that you can hear. So our first innocent murmur is actually the Still's murmur. And it was found by this guy called someone Still. And they're actually not sure exactly what the pathophysiology of the murmur is, but they think it's a resonant phenomenon of blood that's moving into the aorta or across the chordae tendineae of the ventricle. And it's a systolic murmur that's low in frequency, and it's heard between the left sternal border and the apex. Importantly, it's usually found in small children, age 3 to 6, and disappears completely by adolescence. And this murmur will actually have great variability with positional changes of the child, so that your murmur will actually become increase in intensity by lying down or by a hyperdynamic circulation, and decrease in intensity of the murmur by decreasing the ventricular preload. So if you get the child to sit up or stand up or Valsalva. Our next innocent murmur is a pulmonary ejection or flow murmur. That's a systolic murmur that's actually heard over the left upper sternal border. This murmur is the most common in adolescence, and it's between 5 and 14 years of age. And it's got the similar increase and decrease in intensity as our stills murmur. So lying supine, decrease with standing upright. And they think this murmur is actually heard just due to exaggeration of the normal ejection vibration that you would have going radiating up into your neck region. Sorry, I don't have a sound for you guys there. And then we have this venous hum, and that was the murmur I said didn't actually follow all of the 7 S's of a innocent murmur. It's a continuous murmur, so it has a diastolic portion. And you'll note when we talk about pathological murmurs that actually having a diastolic portion is bad. That's usually pathological, but in a venous hum, it's not. It's heard in the infra and supraclavicular borders, usually around the same age as those with the Stills murmur, and it's only audible when the patient is upright. So it has different features to the Stills murmur and the pulmonary ejection or flow murmur. And they think that the murmur is actually caused by vibration of the veins carrying blood from the head and the upper body into the superior vena cava. I hope you can tell that that murmur is a lot more musical. It sounds like a blowing murmur and not so harsh like the systolic and diastolic murmurs we heard earlier. All right, so we've spoken about the most common types of innocent murmurs. What are the pathological murmurs? And obviously, it's outside of the scope of this talk to give you sort of a rundown on every single one of the pathological murmurs, but I'll just chat to you about the VSD, the ASD, and PDAs. So pathological murmurs are diastolic or mid or pansystolic. So a pansystolic murmur is never an innocent murmur, and a diastolic murmur is never an innocent murmur in general context. It's grade 3 or higher, it's very harsh, whereas I was talking about the change in position, changing the intensity of those innocent murmurs. A change in position doesn't change the intensity of a pathological murmur. It's either grade 3 or grade 4, or grade 5, or grade 6. Importantly, you will have additional sounds. You might hear an opening snap, but this fixed split S2 is something that's quite common because of the left to right shunting that does occur. And you'll hear a split in your S2 component of your second heart sound. So the first thing we're going to speak about quickly is our ASD, so atrial septum defect. These defects are actually usually associated with endocardial defects, so may include valvular and VSD lesions. So 15 to 20% of ASDs are usually associated with a VSD. They're also associated with other cardiac defects such as tricuspid atresia, transposition of the great arteries as well. ASDs themselves don't particularly cause a murmur, but you do have associated murmurs with an ASD. So you can get a mid-systolic or a pulmonary ejection murmur, and then you can get a pansystolic murmur or a murmur of a mitral regurgitation. And the mitral regurgitation murmur is obviously due to associated left ventricular dilatation and hypertrophy because of the left to right shunt. You get increased blood flow coming to the left side via the pulmonary veins eventually. And then you do get dilatation of the left side as well as the right side. So our complications are left to right shunting, cardiac failure in adulthood if it's left untreated, AF or atrial fibrillation, and pulmonary hypertension. So these are just some of the investigations that you can have with an associated ASD. So what happens is with your left to right shunting, you get overflow of the right side of the heart with increased blood, and that can lead to right atrial and right ventricular dilatation, and then eventually to increase in the pulmonary vasculature. So there's more blood flowing there, and you will see that with the arrow pointed top left as well. And then there's this really cool sign called the crochetage sign, and this sign by an article by Lei Shen in 2018 they actually found that 28% of patients with ASD had the characteristic R-wave notching in the inferior leads, as compared to 2% of control patients that don't have it. So with those arrows at the ECG, you can see that there's notching of the R-wave in leads 2, 3, and AVF in those inferior leads, and that's the crochetage sign. This sign is usually associated with slight right axis deviation, as well as signs of a right ventricular hypertrophy on ECG that you would see. So if you see these features all together, be very suspicious of a large ASD. This is just a transthoracic echo showing parasternal short axis. And over here, we can see that is our sort of Mercedes-Benz, so at the aorta area, and you can see the shunt going into the right with this sort of huge jet flow of blood this side. Okay. All right, and then the other cause for our pathological murmurs is a VSD, and this is actually the most common congenital heart lesion. VSDs usually are can be of the AV canal septum, of the muscular septum, or the distal conal septum. Most of the VSDs, about 80% of the VSDs are perimembranous. And VSDs can be isolated, but actually are usually associated with the congenital sort of syndrome, like your tetralogy of Fallot or your transposition of the great arteries as well. Most importantly with VSD, with moderate to large VSDs, is to look for signs of heart failure in this child. And we know the different features here that we discussed. So not only asking for the symptoms, but looking for the signs, specifically the hepatomegaly, the poor weight gain, the failure to thrive, the poor feeding, the sweating during feeding as well. Then the clinical presentation of the VSD murmur depends on how large or small the murmur actually is. So the larger the murmur, the less the sound you're going to hear, because there's less of a pressure gradient to produce that turbulent flow so that you hear a sound differential, essentially. So I've just put some numbers there. I don't think those are particularly important to note offhead, but it's just the concept that the larger the murmur, the less sound you're going to usually hear. Note that in addition, if you're hearing a diastolic murmur, it actually does indicate that there is a left to right shunt going on. And then a loud S2 or an exaggerated split is what you're going to hear in a moderate to large VSD as well. This is the Katz-Wachtel phenomenon. So this is an ECG of an isolated VSD, and the most common changes are left atrial enlargement and left ventricular hypertrophy due to the left ventricular overload by the pulmonary circulation, which goes into the pulmonary veins and overloads the left side eventually as well. And then we also see this biventricular hypertrophy sign. So we can see signs of left ventricular hypertrophy as well as right ventricular hypertrophy. And this Katz-Wachtel phenomenon is known as the biphasic QRS complexes with high amplitudes of more than 50 millimeters in the leads V2 to V5. You can also see features of right atrial hypertrophy and features of right ventricular hypertrophy as well. So that's just a cool ECG finding. And then we've got here a parasternal long axis view of a membranous VSD. Those are the most common, remember. And the defect, I hope everyone can see, is over here. So if you look at this picture over here, here's your left ventricle, and that's actually shunting blood into the right side system. And you can see this sort of jet of blood here indicating the shunt. All right. And then last but not least, in sort of our scope, the PDA murmur, which is a pathological murmurs. PDAs can occur quite frequently. It has a female to male predominance. And actually the incidence of PDA is greater in infants born of high altitude compared with those born at sea level. There's also an association, not a causation, but an association with PDAs and congenital rubella infection. But one of the most important risk factors for developing a PDA is actually preterm birth. So the presentation of a PDA likely depends on whether or not it presents early or late. In the early presentation, it'll be loud, it'll be that machinery murmur, you'll have a split S2, you'll have bounding pulses with a wide pulse pressure. If they present a little bit later and it's an uncorrected lesion, you might have reversal of this left to right shunt, which is known as Eisenmenger's physiology or syndrome. And what happens is that because of all the extra blood in the right-sided system, the pulmonary pressures get so high and you have pulmonary hypertension that those pulmonary pressures become actually higher than the systemic pressures. And then there's a reversal of the shunt, and now the child will become cyanotic. This is a lot harder to see, so I apologize for that. But this is a parasternal short axis view. And we're trying to look here above the aorta with the Mercedes-Benz over there. And we're trying to see that there's a jet this side. Here's a nicely labeled echo that you guys can just look at a little bit later. And then this is just a nice summary. It's in our ED protocols of the Rahima-Musa protocols, just of the different areas that we're going to hear our various pathological and non-pathological murmurs, or innocent murmurs, and which characteristic of innocent murmurs we should be looking for. And remember, they have to fulfill all that criteria to be called an innocent murmur. Okay, so now we know how to recognize it. How are we going to manage it? And I think the important part of management in these patients is to know when to refer to cardiology immediately, when is a possible delayed referral to cardiology or peds indicated, and when it's okay to watch and wait or, down refer them to their general practitioner. And I found this really nice summary. It's in the references as well, but basically a neonate with no dysmorphic features. You've taken the family history. You're not kind of concerned about anything particularly. You've checked for all of those things that we said you checked for on history. So now you examine the patient, and if the murmur is diastolic, refer them to a pediatric cardiologist. All diastolic murmurs are pathological for our intents and purposes. In terms of if it's systolic, are you seeing signs of heart failure or critical congenital heart disease? If you are, you refer to a pediatric cardiologist. If there's no signs of that, and we're also not seeing any suspicious features of our history of a congenital cardiac lesion, then we can listen to the murmur and decide, okay, cool, does it sound like it's an innocent murmur or does it sound pathological? And we can actually listen to the murmur the next day. If the murmur completely disappears, they actually say that routine care can be taken, no referrals actually necessary. And if the murmur persists on the next day or subsequent examinations, then you actually can do a pediatric consult, but an outpatient consultation. In terms of heart murmur evaluation beyond neonatal period, we're going to look at the characteristics that we said were those of an innocent murmur. If the murmur has any characteristics that are associated with a pathological murmur, they need referral. However, if the murmur has features of all those 7 S's, then we're going to usually go down the left side of the pathway and take a really extensive history and really see if the patient has any other signs of heart failure. If everything is negative and we think an innocent murmur is actually likely, then we're just going to reassure the patient. But if the murmur persists after the completion of puberty or for longer than 5 years of monitoring without a diagnosis, then you're going to consider actually referring that patient to pediatric cardiology. So quite simple tables, but really consolidates everything that I've said in this whole talk about what's important in terms of the murmur. And then just to go through our quick management of heart failure, remember we're going to manage shock and related life-threatening complications first in our ED. Then we're going to correct reversible conditions or things that might be aggravating this heart failure state or the decompensated heart failure state. So things like anemia, renal failure, respiratory disorders, anything like that, we're going to manage those. Then we're going to provide relief of symptoms of heart failure and prompt referral of our pathological murmurs. And here, just to remember that we're going to manage shock specifically in our kiddies with milneuron, dobutamine, or dopamine, specifically with our inotropic support, and also manage shock with our positive pressure ventilation of any type, whichever, high flow, CPAP, or BiPAP. And then the medical management of heart failure, which is usually going to be left up to our pediatric colleagues. And that is actually extrapolated from adult data because they haven't done much data on children, but this is sort of the adult management that we know. But like I said, this will mostly be established by our pediatric colleagues. And that is it. That's all I have to say. Thank you guys so much for attending. Yeah, if there's any questions or comments.